Moving on to the next session, terminal care of COPD patients in primary care. The chairpersons of the next sessions will be Dr. Priyantha Halambarachi, consultant family physician, and Dr. Janaki Vidanapatruna, consultant community physician. And our lecturer will be Dr. Kirthi Gunasekara. Yes, and there's a photograph will be taken with the chairperson and the speakers. To conduct the next session, once again, I cordially invite Dr. Priyantha Halambarachi and also Dr. Ms. Janaki Vidanapatrana.
Good morning, and it's my pleasure to introduce Dr. Kirthi Gunasekara. He's a consultant respiratory physician over 20 years of professional experience. He's the national coordinator for ISAC International Study, the BOLD Study, and Arnold Study in Sri Lanka. He was a past president in Association of Pulmonologists Sri Lanka in 2009 and Ceylon College of Physicians 2014. Dr. Gunasekara was awarded with the prestigious National Award for Healthcare Excellence in 2008 by the government of Sri Lanka. Over to you, sir.
Good morning, everybody. And I wish to thank the chairpersons for the kind words of introduction and also the Sri Lankan College of Specialist Family Physicians for having given me the opportunity to speak to you about COPD palliative care in primary care. Firstly, before I start off, I wish to congratulate Professor K for her wonderful lecture and the concept of partnership. I think conceptually, taking Sri Lanka, this concept is very, very vital because treating our patients and partners as equal, which I feel is a big barrier everywhere, right? Everywhere, because I work with a lot of tuberculosis, and we find that the stigma and the main problem of containing this disease is that we have not developed a strong partnership with our patients. So I think that's a wonderful lecture, and thank you very much for that. Now I will proceed with, I was supposed to talk about terminal care of COPD patients, but I thought it would be more appropriate to talk about palliation because we take it a little bit further and what we can do more than when the person is dying or very terminally ill. And hence I changed my topic to COPD palliative care. Now why COPD? COPD burden is growing globally. It's one of the top three causes of death. And a lot of patients are from our part of the world, though we think that it is smoking related and it was in the West, but no, it's mostly in the low and the middle income countries. And this is very, very important. And it is preventable and treatable, causes a lot of morbidity and mortality. And also because of the aging, we are living longer and hence we are seeing more COPD everywhere. Now, what is the situation in Sri Lanka? This is roughly these old data from about 2012, but when I looked it up, it's almost the same. We have about 30,000 patients admitted to state hospitals with COPD every year, and we have about 1,000 deaths of COPD every year in this country. And I had the privilege of conducting the first prevalence study in the country from all the provinces. And here we found that our prevalence is about 10.5% of patients have COPD in the community, which is quite a lot. When you look at this, these are the deaths, and this is the one showing the prevalence of 10.5. And if you look at, India has only 7.5 recorded prevalence. We are having a very high prevalence of COPD. However, in the community, what we found in this study, this was an international collaboration globally, we found that our COPD, especially in the community, were more mild to moderate COPD. We are not seeing the cohort that we see that comes to hospital, that the very severe COPD cohort is less in the community, and we have the mild to moderate people who are misdiagnosed as asthma. Especially, we have a large non-smoking COPD population in the country, and this is why we are having a very high prevalence. Now, what is COPD? When we remember that it is a serious respiratory illness with years of progressive debilitating breathlessness and also associated with depression and anxiety and frequent hospitalizations, right? So we have to remember that these are progressive thing which is going on with patients, and the objectives of this lecture is to identify the role of the primary palliative care in patients of COPD, for earlier integration of routine practice and the domains of what is palliative care and what are these special domains in palliative care and the triggers initiating palliative care, and I'll be using some case-based examples to illustrate this management. What is palliative care? Sorry, yes. So palliative care is an approach to improve the quality of life of patients and their families facing problems associated with life-threatening illnesses with physical, psychosocial and spiritual aspects. So this is going beyond the realms of treatment only. So when you take palliative care, if you look at the, if you look at the line in red, you can see how the patients with COPD and heart failure behave. You find that these dips that you see are due to the exacerbations, and historically, you can see that at the end, earlier palliative care was close to death, but now we are trying to, so you can see historically it was provision of late palliative care, but now you can see this other gray line, which is early intervention with palliative care, improving the quality of life. So I'll talk about this later, so that as we prepare the patient for when the disease progresses to cope with his illness better. So what are these domains that we talk of? As clinicians, we are used to treating patients with pharmacological agents, but here when we have to go outside that, and these are the project domains of quality palliative care. You can see there is a physical component, of course, which has your treatment, the medicines and the inhalers and the oxygen therapy, etc. I'm not going into details of this. There is a psychological and psychiatric component, social, spiritual, and cultural component, and of course, the end of life and ethical and legal issues which we have to address in these patients because they undergo a lot of suffering with this. So let's take this case history of Mr. S, a retired accountant, 65 years, diagnosed with COPD during the last 3 years. He's short of breath when he does his daily activities and debilitated due to illness because of his dyspnea. And currently, Goal 3, Group D, has severe COPD with no significant comorbidities. He also has a productive cough throughout the day, on and off, with mucopurulent sputum, and sometimes he has bad odor, which is causing him social embarrassment. These are real problems that people undergo. He also complains of post-operative chest pain, and it compromises his sleep. His caregiver is his wife, who was a retired nurse, and she also has osteoarthritis, and they live off their pensions and financially stable due to their savings. 2 children overseas, and parents receive no emotional support. Now you know that these are very common scenario where we face, where the children are now employed, they don't have time for their parents, and they are isolated. Since his last admission, he's worried about his wife in case something happens to him, right? So these are practical problems, right? He's on optimal medical management. He had attended a pulmonary rehabilitation program 1 year back, which was very helpful. In spite of all, he has become a very frequent visit to the clinic and comes often prior to the appointment, enjoys gardening but can't do anything because of the shortness of breath. He's a devoted Catholic and confesses being anxious and suffers from depressive symptoms very frequently. So what more can we offer? So these are the different areas that we can help: physical, psychological, social, spiritual, practical, end-of-life management, loss, grief, and disease management. This is just a summary of the areas that you have to think outside the box when you see a patient like this. So the physical domain, he has advanced COPD with marked breathlessness and considerable assistance to maintain activities of daily living, right? And he has, a lot of these people with breathlessness have panic attacks because they feel that they are getting strangulated, they can't breathe, please help me, that kind of thing. Cough leading to sleep disturbance, social embarrassment, and post-operative chest pain. Psychosocial dependent, worried about dependency on his wife and about the well-being of his wife in case something happens to him. and or he's also anxious and suffers from depression, feels frustrated that he's unable to enjoy his leisure activities like previously, and also he's spiritually feeling guilty that he can't attend Mass, being a Catholic, because he can't go for Sunday Mass because due to his breathlessness. So now when you take breathlessness as a symptom, it's a subjective experience and has distinct sensations that vary in intensity. Sometimes it's mild, sometimes it's very, very bad, right? But this sensation is derived because of interaction amongst a lot of things, like physiological, psychological, social, environment. So many factors come into this giving this symptom of breathlessness. And also it results in a lot of physiological and behavioral responses. Now, when you take breathlessness per se, there are three predominant cognitive and behavioral reactions. One is the breathing aspect, the thinking aspect, and the functioning aspect. Now, breathing, inefficient breathing causes increased work of breathing, and there's the respiratory rate will be going up. He'll be tachypneic, using accessory muscles, and there is dynamic hyperinflation, as you know. Thinking, thoughts about dying, misconceptions and attention to sensation, memories, and past experiences. This results in anxiety and depression. And functioning, of course, because of reduced anxiety, tendency to self-isolate and dependence on others, and also deconditioning of limbs and chest wall and accessory muscles. So this vicious cycle is the strongest driver of breathlessness. So it's not only the cause of the bronchospasm that we think of or the hypoxia. So all these things add up to cause the sensation of breathlessness in this patient. Dyspnea can be episodic or continuous, and if it is episodic, it can be triggered or non-triggered. And of course, exertion, emotion, environment, all these things can trigger the breathlessness. Now, how do we apply these principles to this patient? Breathing cycle, does he have features of dynamic hyperinflation? You know, the puffed up barrel chest, and they can't breathe properly. And is he having ineffective breathing techniques? Thinking cycles, is there anxiety, which is aggravating his breathlessness? Is he having panic attacks? How does he deal with them? And functioning, are the muscles wasting and deconditioned? And has this led to social isolation? Because a lot of these people don't want to come out to society because they will be getting cornered, and they don't want to because they have led very good lives, and they don't want their image spoiled because of coming into society in a debilitated manner. So when it comes to treatment, you have the non-pharmacological and the pharmacological treatment. So thinking of the same areas, so we have the breathing. When you take the breathing, of course, we can help them with breathing techniques, handheld fans, airway clearance techniques, inspiratory muscle training, chest wall vibration, and of course NIV, non-invasive ventilation. So these are some aspects. These will contribute in a little way, but all these things together will of course help him. And thinking, cognitive behavioral therapy, relaxation techniques, mindfulness and acupuncture, functioning, pulmonary rehab, activity promotion, walking aids, pacing, and neuromuscular electrical stimulation are some of the things that we can offer. Now, this is something, breathing techniques, forward positioning, and pursed lip breathing. Why pursed lip? Because you create a positive pressure, and the early collapse of the airway is prevented by pursed lip breathing. Fixing the shoulder girdles improves the efficacy of the accessory muscles and improves gas transfers. And we also can have controlled, I'm sorry about this, I don't coordinate this. Right, so this is the breathing techniques of the positioning and the controlled breathing techniques of how we can assist in a patient to lift something off the ground. This is just sitting with one knee, and how to exhale while pulling the luggage and control. So these are little things that we can help. And this is a facial cooling and handheld fan. How does this help? It interrupts signals from the upper airway to the brain stem respiratory center. Right? So these are some of the things that might help when they are very, very breathless. Walking aids, of course, allows forward leaning and decreases breathlessness and gives patients confidence, because mobility is very, very important, because this also distracts them. When they go out and then they can do something, it distracts them and gives them a better quality of life. Pulmonary rehab, of course, we all know about it, right? There is a team. It's not only the physiotherapists, it's a team of people all together, and there is a lot of components in this. It's not only the exercise and training, but breathing management, nutritional support, energy, interdisciplinary education, all these things, self-management. So it's a complex thing. I don't dwell into this, but actually some of this is happening in the country, but we have not been able to bring it to the private sector because of the cost factor. But in the Valisara, we have a pulmonary rehab unit, and then also at the chest clinic. But in practice, to get it into the private sector has been a problem because of the financial issues. Then treatment of dyspnea, of course, we are ethically obliged to treat dyspnea. It's important to know the intensity of their breathlessness. And what about opioids? Opioids can be used, dosed and titrated for relief of dyspnea. And specific treatments, we have to look out for adverse effects as well. And it's important for clinicians to communicate about palliative and end-of-life care with their patients. Now, this concept is a little bit difficult in our society. As you know, this concept of end-of-life care is a bit difficult to convey unless you win the trust of the patients very well, right? And give them the confidence, because in our society, a lot of people will try to ignore that section completely and turn a blind eye and let life go on. And the family also will say, no, we prefer the patient not to know that he's dying or something like that, or that he's bad. So these are very common concept that we face in our country. So use of morphine, what do opioids do? They reduce the spontaneous respiratory motor response to hypercapnia. So when you take the dosage, you can start with slow release morphine 10 milligrams, then we can go up to 30 milligrams a day. But our main problem is we are worried about whether opioids hasten death, but it's not associated with respiratory suppression. As as medical officers, we are all very scared about this. Survival time was not related to dosage. No change in arterial blood gases or oxygen desaturation. So those are the very, very important things. Proper titration relieves without hypercarbia or hypoxia. So carbon dioxide doesn't go up if you titrate it properly, and there is no hypoxia if you do it properly. The other aspect is, should depression and anxiety be assessed independently? Of course, you have to be careful of this, and we can use low-dose benzodiazepines if you find that they are very anxious, and modest benefit of midazolam, particularly in combination with morphine. Now, subsequently, there is your call from the ETU that he is admitted with an acute exacerbation of COPD, makes a quick recovery, and is discharged after 5 days. Now, these are common things that happen. These people get into hospital and get out, and you feel that he's okay, but then he relapses again. So it is important to prognosticate this patient before discharge, and what is the reason and how do you do so, right? When a patient, now this is the time when the patient is discharged from hospital and comes out. Now this is very important, right? Now, importance of advanced care planning. Now this patient has a good insight about his illness, but has poor coping strategies. He can't cope with his illness. He has no unfinished goals, but has an unfulfilled wish that he could reunite with his children living abroad. Now, this is something very commonly seen. You find a lot of parents going to see their children overseas now. Why we get so many referrals for visas. A lot of these people are living alone with so many diseases all the time, and they try to go to see, because they've been nurturing the children lifelong. That has been their duty, and now they are alone, and they're trying to cope with this, and they're coping with their illness as well. So it is a very, very tough thing, which we as doctors should understand, right? He and his wife are financially stable, but there are legal issues regarding wealth which are not settled yet. This is another issue, because they are worried if they write everything to the children, they don't have money, they will have to beg their children for money. They don't want to do that because they've been independent, right? So they don't know when to write, what to do. So these are common problems that parents face. His expectations to better cope with his shortness of breath and improve, but he wants to cope better with his shortness of breath and improve the quality of life before death, and to die in a dignified manner. That is what a lot of people want. And also, they don't want to have invasive or non-invasive ventilation or any interventions to prolong life, so they want to go off soon. So these are some of the requests that these people have, which we must understand. So coming on to the total management finally, we should evaluate the cough, because cough is a problem. Very often this coexists with bronchiectasis, and sometimes these patients have, in our part of the world, have had TB and the lung is damaged. And we have to understand that there is stasis of phlegm in the chest, and therefore effective secretion clearance and protecting them from recurrent infections is vital. All three components of the breathlessness cycle was affected, so thinking, functioning and everything. So for the thinking cycle, we can help him with controlled breathing techniques, handheld fans and relaxation methods, particularly for panic attacks, reassurance and counseling, and sometimes anti-anxiety medication. Pulmonary rehabilitation is very important to get them active again to the maximum that they can is very, very important. And mobility aids, as I said, and energy conservation, and again nutrition is also important. Have regular palliative assessment, evaluate domiciliary oxygen and even CPAP if necessary. Optimize pharmacological measures. Now, very often, as a chest physician, I find that these people take inhalers. A lot of people, doctors, prescribe inhalers, but the inhalers don't get into the patient at all. Nothing goes in. It's an absolute waste of money. The MDIs, because these people, these COPD patients can't use dry powder inhalers because their inspiratory flow is very low and they can't suck in. They are the ones that people like, but they can't do it. So invariably you have to give the MDIs. But just because you give an MDI and a spacer, it doesn't help. Because this is something very foreign, not like a pill or a tablet for a syrup or something like that. My colleagues have completely forgotten this aspect. Lot of inhalers are prescribed, but nothing goes into the patient. This is very sad. And particularly in these patients, I have noticed that if you use small volume spacers, because remember, with your inspiratory flow, a small volume of air is easier to mobilize. And if you can have a mask fitted to that, these people can breathe easily. These are practical. So if you can't, here, we have financial constraints, but you can use a Cipla baby mask and fit it and get the people to use it. They do very well. Even the most breathless patients, because they can't go for nebulization, they can't afford nebulization. So in this situation, remember, this is a very important aspect that you have to think of when it comes to, I'm not coordinating this, yes. So this is the first part of management. And of course, strategies to prevent exacerbations, right? Your vaccinations, do you need to give them prophylactic antibiotics? Nutrition, very important. Depression, psychological support, and psychiatric referral if needed. And also, I think what Professor K was talking about, the carer. We forget about the carer. We forget about that old lady, the wife who is with him, who can hardly walk herself, who is caring for this person. This is becoming more and more common in our practice as well. It's not only in the Europe, but it is coming because a lot of people are managing alone, right? And we don't have a proper social support structure to look after these people. So as physicians looking after these patients, it's our duty to look into this and to see whether how they are going to survive. This is something actually a broader perspective which we all have to get together, and this concept of collaborating with people and getting together with people, support groups, is very vital, because the doctor from the hospital has no connection with the the primary caregiver or the support systems in the community. So this link has to be strengthened, right? We have to work together if we are going to actually look after our patients well. Reuniting with family members, sometimes as a doctor you have to talk to people and of course discuss with the family about legal issues such as wealth and properties, an update containing concerns regarding the advanced care planning, what happens if it gets really bad and how. Because I can remember there was a similar patient, two teachers, the one was a principal and the wife was also a teacher. Husband was a bad COPD patient living off Piliandala. They were totally alone. Both children are very high professionals in Australia and one in the UK. They are totally alone, absolutely desperate, right? Sometimes I visit these people trying to help them to the maximum that I can. But it's very, very sorry. It's a very sorry situation because the wife who's looking after him is equally weak, right? So somehow he passed away about a year ago. But until then, it was a long struggle because they are educated and they know what is happening, but they can't cope. And we don't have a social structure where we can support these people. This is a very common scenario. And of course, we must know when we have to refer these patients for when they are very ill, right? If there is very severe airflow obstruction, breathlessness at rest or minimal exertion, refractory breathlessness, saturations less than 88 oxygen, hypercapnia, copalmanale, dependence on oral steroids. This is also very commonly seen because of desperation. They can't buy any medicines, which the inhalers, which are expensive. Frequent severe exacerbations, low albumin, very often we don't think of that, unintentional weight loss, and of course, decline in activities of daily living. So these are things where we have to think of referral. So in conclusion, we have to realize that primary healthcare support for seriously ill COPD patients is greatly neglected in our country. And palliative care provides some comprehensive support for these COPD patients. It has several domains, which I have told you earlier. It's not only appropriate that the very end of life and the ICU, it's not only appropriate at the end of life. Remember, we have to start early, right? And should begin long before the person reaches severe COPD. Ideally suited before someone experiences significant decline in their well-being and functional status, and provides support for symptoms such as pain, refractory breathlessness, and near end of life, prepare the patient and families for death, and support the families with respite care and bereavement. Thank you so much.
Thank you very much, Dr. Kirthi Gunasekara, for highlighting very challenging situation in Sri Lanka. So not only Sri Lanka, global wide also, it is the third cause of the mortality. Same scenario we can see in Sri Lanka too. And also he highlighted epidemiology part as well as the different mode of treatment modalities. So that really highlight different physicians, they practice in different way. And also he highlighted need of private-public partnership. So at the same time, I request College of Specialist Family Physicians to start developing the strategic plan for the chronic obstructive pulmonary disease as well as the treatment guideline that really help Ministry of Health to process for improve the quality of life. So now the floor is open for questions.
So thank you very much for that wonderful lecture presentation. And as family physicians, we come across a lot of COPD patients with acute exacerbations. In that scenario, what can we do, sir?
Yes, so acute exacerbations, first we will have to try the nebulizations first, right? Because most of these people are not nebulized, they are on their inhalers. So when you nebulize, you give a very higher dose of the medication than getting through the inhaler. So we'll be using the beta-2 agonists and the antimuscarinic receptor antagonists like ipravent and salbutamol, which is important. But very often these people have an infection as well. Now for infective exacerbations, it is recommended that you give some steroids as well. So sometimes even using budesonide as you can use piperacillin as well in this situation. It's just see how he responds. And with, particularly you'll have to check the saturation and see, and then check whether there is an infection going on and treat accordingly, and then whether he needs supplementary oxygen. So this is something that a lot of people need, but now I think the Ministry of Health has on principle agreed to provide oxygen for these people who are requiring. So that's a very big step. I think Dr. Ravinikar Nathilaka has pioneered that, which is a very big thing for these very serious patients. But if you find that he cannot be to control, then of course you have to refer for admission for most probably a non-invasive ventilation support at this time. Because there are definitely areas of surgery and stuff like that which is recommended in the bronchial valves and all, but still in our country there are people who go to Singapore and get it done if you have upper lobe emphysema and all that. Then of course in the long term we have to think of smoking cessation, exercise and pulmonary rehab and the whole works, as I said.
Thank you very much for your very wonderful lecture. I think you have highlighted the point that end-of-life care and the palliative care, and it's very stigmatizing, then the people don't accept. I think it's a very good forum to discuss, because the College of Palliative Care President here is with us, Dr. Janaki Vidanapathirana. I think she can talk about that, how we can give some support for these guys.
Thank you very much, Dr. Lalanta. Actually, now we have a strategic plan for the palliative care, but still Sri Lanka is in very infancy level. So it highlighted different strategies that includes community palliative care too. And also, as Dr. Gunasekara mentioned, very recently, Ministry of Health issued a circular for providing oxygen for the community care. That really still there is some challenge, because all the oxygen cylinders belong to the inventory. So that really highlight we need to community public partnership. We don't have in clinical care community public partnership. That is the main thing. For we have a very good community public partnership through NGOs for STI and HIV care. So the same model we have to find out the NGOs who are working for these disease areas, and we have to provide that. So this and also there is a thing called the social contracting. Social contracting is the services that cannot be provided by the government. You have to contract the NGOs. That model we can apply for all the palliative patients, those who are at community level. So we have a long way to go. So then actually most of clinicians as well as the healthcare providers, still they are not thinking about the palliative patients. So we have to start that.
Sorry, I need to add a little bit, because now we have to understand that our social structure is changing. We are living longer, right? Unlike those days, so the elderly population is getting more and more, and the younger people are all being educated and they try to go overseas or something. And the nuclear family units are becoming more prominent. Except perhaps in the Muslim community, you find that still the community support is very high amongst them. But all the others, now even in the estate sector, even in the plantation sector, all the children have gone and the old people are at home. So we are running into a big health crisis, which we don't anticipate, because all this time we were only focused about therapeutic aspects, hospital-based and the clinic-based practice kind of thing. But now we have to move. But who is going to look after these people? The elderly homes are getting more and more filled. People are looking for small flats to how are we going to survive, how are we going to live, what is the support. So we haven't, the country has not looked about this in a broader sense. So I think this is where the medical professionals also have to play a very much larger role here. Thank you.
In case of management of acute exacerbation, as the way Dr. Priyantha mentioned, I would like to get your opinion to have the nebulization of oxygen more than at the time of exacerbation. The patient is in a very distressed time, rather than the bronchodilators and all, because it will be helpful to the audience as well.
No, nebulization with oxygen is very, very useful, particularly if the patient is hypoxic. But very often, if you look at these people who come, they are not hypoxic. They are not hypoxic. But yet, they'll be asking for oxygen for relief. This is a common thing. So there is the use of oxygen in that sense without hypoxia doesn't seem to be very rational. But sometimes these people long for that because they just want something to relieve their dyspnea. So that is the problem. So that's why we have to think of so many other factors when it comes to, particularly in panic attacks and things like that. We have to learn. We haven't used these strategies much because we are more focused on, treating the acute thing, not thinking of whether this is actually pathological or not. So that's very important.
Any more questions?
Seems there are no questions, and that concludes the session on terminal care of COPD patients in primary care conducted by Dr. Kirthi Gunasekara. Thank you very much, sir. And I cordially invite the chairpersons, Dr. Priyantha Halabara and Dr. Janaki Vidanapatrana, to give away the token of appreciation to our presenter. And please come onto the center stage so that we can take the photograph as well with the certificate and the gift.